What we're going to look at is the effect of devitalized tissue on the skin for patients with edema, so lymphedema, chronic edema, and leg ulcer patients. So the four mainstays of edema, which we know, are skin care, massage, exercise, and compression. The skin plays a vital role in assisting lymph flow and venous return. We know that, but also healthy skin with good elasticity facilitates massage, exercise, and improved surface for compression. But devitalized tissue can compromise the skin. So if we look at the research, we find that hyperkeratosis, we have the build-up of cytokines in the skin, and that leads to reduced mobility, the risk of edema, and the risk of infection. And that then, in turn, reduces the lymph flow, produces more edema. That could lead to infection and leg ulcers, and that leads again to inflammation, and finally, that perpetuates the hyperkeratosis cycle. So you can see that what happens in the skin affects the lymph flow and the venous return, and then builds up the hyperkeratosis again. So it's a vicious cycle, and we do need to make sure that we get rid of that. What we look at now is the research that goes back as far as 1955, when Butcher and Hoover looked at the superficial lymphatics that sit just between the upper and mid third of the epidermis. So we know that the deep lymphatic vessels play an important role in producing edema. What's not known really, or it's very little knowledge about, is that the superficial lymphatics, which sit very close to the skin, also play a role. And when those superficial lymphatics become damaged and compromised by hyperkeratosis that builds up in the skin, then we have reduction in lymph flow from the top as well as from within, from the deeper vessels. The research also shows there's an obliteration of vessels in trophic skin conditions, and that was from Mortimer, Browse and Bernand in 2003. And here we have some of the top researchers in lymphedema talking about the superficial lymphatics in the skin and what happens if you have compromised skin. So if we look at what happens to the patients with hyperkeratosis and papillomatosis, Terence Ryan talks about the loss of barrier function that can occur, and that's very up-to-date research in 2013. So what happens is you get the water loss that occurs, but also the uptake of emollients can be affected if you have skin that looks like this. Assessment can be obscured, so if you look at that particular leg, what's going on there, it's very difficult to tell. Removing the debris from between the cracks and fissures may be difficult in papillomatosis, so you get the lumpy, bumpy appearance of the papillomatosis, but in amongst that, very much like tiles on a floor where you get the debris settling in between the grouting, well, so you have the debris sitting in between the papillomatosis, and you need to get rid of that before we can look at anything else. And compression flattens and improves the papillomatosis and the skin tone to encourage lymph flow. So what you have is the compression working from within to flatten the papillomatosis and reduce the edema, and you get the debridement from the outside, looking after the top layer from the outside. So in the case of cellulitis caused by skin infections, the presence of devitalized tissue we know on the skin can form a focus for infection, and that is a real problem for us, really, with patients with leg ulcers and lymphedema. And that can become systemic, which again is very, very much of a problem. A byproduct of debridement is also the excess fluid that can cause maceration and excoriation. So we really need to make sure that when we look at debridement, it happens very quickly, because cellulitis can happen very quickly. So we do need to really get rid of that devitalized tissue that's causing the problem on the skin. Complications are pain and disruption to compression therapy with the added cost of treatment. The simple little flowchart shows that the removal of devitalized tissue can improve the wound and the skin. The It can give you good skin conditioning. This visual wound assessment is assisted by debridement. It manages the infection by removing the debris away from the skin, and fluid management. And that is the same for wounds as well as the skin. So you need to make sure that the fluid is taken up into the products by debridement. Appropriate follow-on treatment is then facilitated, so once you can see what you're doing and you've removed the fluid, you've removed bacteria, you can then look at follow-on treatments such as compression or wound dressings. Alongside that, we have the patient comfort. Patients who, particularly at the ankle, if they have the keratotic tissue that's built up around the ankle, we know that that's a problem area and they don't move, and because they don't move, then you don't get the lymph flow again and you don't get the venous return, and so that goes on. So we have improved concordance and mobility if you have effective debridement, and finally that would progress on to healing, and that's our ultimate aim. So what can we do? We can aid assessment by good debridement, improve the skin condition that will not only help the patient, but aid assessment. We can improve the lymphatic flow by helping the superficial lymphatics as well as the deeper lymphatics. We can improve mobility, which for our patients is a very, very key part of treatment. And improve comfort, and as we know that improved comfort means that the patients are more concordant with their treatment. Reduce the risk of infection by ensuring that effective removal of bacteria and fluid is taken up into whatever it is that you're using. So what we want is a very simple method of debridement that will also be very, very quick, not cause too much distress to the patient, but at the same time be very, very effective and comprehensive. So debridement is a key part in assisting not just wound care, but also in patients with edema and lymphedema.